I'm going to be presenting on pulmonary hypertension today. The reason I'm doing this from a recording instead of doing this live is because I actually am in an office and an elective that the Wi-Fi connection is not very strong. So I pre-recorded this in anticipation of this. So without further ado, let's start with pulmonary hypertension. So a little bit about introduction. Pulmonary hypertension is a rare disease that's associated with a very high morbidity and mortality. There's at least 63.7 cases per 1 million children, including transient pulmonary hypertension. The actual number is not very well known just because it's so rare. So what they have found in some separate studies is that there is a prevalence of 0.7 to 4.4 for idiopathic pulmonary arterial hypertension, which we'll talk about, and about 2.2 to 15.6 for pulmonary arterial hypertension. The majority of the cases in pediatric patients are linked to congenital heart disease, and there's also associations with developmental lung diseases, including bronchopulmonary dysplasia, congenital diaphragmatic hernia, and other things that we will talk about. Rarely, it is also associated with connective tissue or thromboembolic disease, for example, like lupus. And then the takeaway from this is going to be that even though we have a lot of studies in the adult population, there's very much a lack of evidence-based studies in the pediatric population. So a lot of the management guidelines are actually going to be based on the clinical experience of pediatric specialists, like Dr. Ivy, and also it's going to be based on the adult studies as well. So pulmonary hypertension can present at any age, from infancy to adulthood. You have to distinguish between transient and persistent pulmonary hypertension. For transient pulmonary hypertension, the most common causes in children would include PPHN, which is persistent pulmonary hypertension of newborn. You may have seen in NICU already, and also congenital heart disease. For persistent pulmonary hypertension, the most common causes are idiopathic pulmonary arterial hypertension and pulmonary arterial hypertension that's associated with congenital heart disease. The idiopathic form has generally a poor prognosis compared to the one with the congenital heart disease, and that's usually because it's diagnosed later because there's very nonspecific symptoms, and if it is left untreated, their prognosis is actually worse than even adults with PH. So what do we mean when we define pulmonary hypertension? We do mean a mean pulmonary pressure of greater than or equal to 25 millimeters of mercury at rest in the presence of an equal distribution of blood flow to all segments of both of the lungs, should be occurring after 3 months of age and at sea level. The pulmonary artery pressure usually will decrease after birth, and it reaches the adult value around 2 months or 3 months after birth. Note that this definition excludes mention of pulmonary hypertensive vascular disease and pulmonary vascular resistance, which we'll define as PVR. When we say pulmonary arterial hypertension, the one with the A, this is usually pulmonary hypertension in the setting of a normal pulmonary wedge pressure of less than 15 millimeters of mercury. So the pathogenesis of pulmonary hypertension tends to be multifactorial, but for the purpose of this topic, we're going to use congenital heart disease as an example. So when you have a large defect like a VSD or a PDA, you have increased right-sided pressures, and you're going to have blood flowing into the right side of the heart. That increases the pulmonary arterial flow. In the short run, usually there's no change in the pulmonary vascular resistance, but over time, you're going to damage the pulmonary arterioles. And some of those damaged effects include the hyperplasia of the intimal layer of the blood vessels, as well as medial muscularization and hypertrophy. You can also have thrombosis forming in situ, and also inflammatory reaction as well. All of these are going to cause an endothelial dysfunction, decreased reactivity and decreased total circulatory area, and also an imbalance in your mediators, including prostacyclin, nitric oxide, and endothelin production. This all leads to increased resistance in the circulation in the pulmonic circuit, so then you're going to require more pressure to push the blood through the pulmonary circulation. As time progresses, if none of this is addressed, you're going to have right ventricular dysfunction, which can also lead to a reduced cardiac output and right ventricular heart failure. I have basically included some pictures here to kind of explain a little bit about what I just said. So note that the pulmonary capillary pressure usually is around like 7. You can see that the picture on the lower where the squares are, you can see that pulmonary artery usually systolic is like 15 to 30, and during diastole is like 4 to 12 for the pressure, with a capillary wedge pressure of 2 to 10. This diagram on the right, it is just showing that the area that we're talking about, the static column of blood in the black, usually that can be due to either, so we basically took like the picture of a heart, we kind of like dissected it into two parts. Like you see the left side is the right heart and the right side is the left part of the heart. Anytime you can have like a static column of blood in the middle between the two circuits, it can be because you have either increased flow from the right side, so increased preload. You can have something like on the left side of the heart, like an obstruction or maybe a valvular defect, which can also basically cause a backflow of the blood through the pulmonary circuit and then into the right side of the heart, by direction. Or you can have something within the lungs. So those are basically like three main sources where you can have basically an obstruction and buildup of pressure. So the etiology then of pulmonary hypertension, like we said, is mostly going to be idiopathic in our demographic, with congenital heart disease being one of the major etiologies, and the ones specifically that cause left to right shunts. In the preemies, we see that the most frequent chronic lung disease associated with pulmonary hypertension is bronchopulmonary dysplasia. There's also other lung diseases that can lead to pulmonary hypertension, including hypoplasia of the lungs and also fibrosis as well. Also, chronic thromboembolisms can also cause pulmonary hypertension. And I think the one that I found that was interesting is trisomy 21, so Down syndrome. You know that they have endocardial cushion defects. They have a range of things that can actually predispose them to pulmonary hypertension, including lung hypoplasia, alveolar simplification. We already spoke about the congenital heart disease. They have reduced surfactant secretion and production, as well as increased risk for hypothyroidism, obstructive airway disease. They can have sleep apnea, reflux aspiration. All of these are not great for development of pulmonary hypertension. And then, like I was speaking in the diagram before, your left heart diseases, like a valvular defect, can also cause increased pressures in the pulmonic circuit. Connective tissue disorders, and then PBHN as well. So I found this, which was basically a classification system for pulmonary hypertension. They have categorized based on the different etiologies. I'm going to read some of them up so that we're not going to talk about all of them, but it's something for you if you're interested to read up on. So for pulmonic arterial hypertension, you have idiopathic, heritable. You have some genes. The ones that they highlighted are the SMAD9, CAV1, and potassium channel KCNK3 genes. There's also an association with connective tissue disease, HIV, drugs and toxins, portal hypertension, congenital heart disease, and even schistosomiasis. And then you go into the left heart diseases. So you have left ventricular systolic or diastolic dysfunction, valvular diseases, PBHN we already spoke of, and then also left heart inflow and outflow tract obstruction and cardiomyopathies that are acquired congenitally. Some of the pulmonary hypertension due to lung diseases and or hypoxia include COPD, interstitial lung disease, some restrictive and obstructive pulmonic diseases, sleep disordered breathing, alveolar hypoventilation disorders, chronic exposure to high altitude, as well as developmental lung diseases. CTEPH just stands for chronic thromboembolic pulmonary hypertension. And then some multifactorial mechanisms include a lot of hematologic disorders like hemolytic anemia, myeloproliferative disorders, and splenectomy. And other things I see that are you can read on the bottom as well. The ones on the right column are the ones that are usually the developmental things that we can see like in the ICU. So congenital diaphragmatic hernia, bronchopulmonary dysplasia, alveolar capillary dysplasia, lung hypoplasia with surfactant protein abnormalities, and also basically anything that is related to congenital heart disease that we have already spoken about, Eisenmenger syndrome, left to right shunts, and so on and so on. So you can actually look over this, and like each of these is a topic in of itself, but we won't go into the details of all of them. So the signs and symptoms of pulmonary hypertension tend to be very nonspecific, especially in the early stages in infants. But if you do see them, they will have basically like failure to thrive, they have poor appetite, they can have diaphoresis, tachypnea, tachycardia, and irritability. Later on, they can develop syncope, chest pain, and hemoptysis, and in older children, they will have exertional dyspnea with progressive fatigue. The auscultation, on auscultation, you're going to hear a single loud P2 and also right ventricular lifting. You will appreciate also the murmur of pulmonary insufficiency, which is an early diastolic decrescendo murmur, and also tricuspid regurgitation, which presents as a hollow systolic murmur. They can also have a gallop rhythm as well. On your physical exam, they're going to have the signs of right heart failure. So these include jugular venous distension, hepatomegaly, and peripheral edema. Some of the evaluation studies that we will do include obviously ECG. On the ECG, you're going to appreciate right atrial enlargement and right ventricular hypertrophy, and this is usually presented as a tall R wave in V1 and V2. Sometimes may be preceded by a Q wave, and there could be also signs of strain as well that we will see on the next slide. On chest x-ray, they can have a prominent central pulmonary artery, and also something called peripheral pruning of the lung vessels, which is basically you'll see like the more distal ends of the lung arterioles are going to be like basically they look more enlarged compared to a normal lung. Also, if you know like what the underlying cause of your pulmonary hypertension is, for example, thromboembolism or congenital heart disease, you can actually see the corresponding chest X-ray will tell you. When you do echocardiogram, usually is used for assessment of the pulmonary artery systolic pressure, the right and left ventricular size and function. You will assess for shunting and also the presence of congenital heart disease. The gold standard definitive diagnosis of pulmonary hypertension is a cardiac cath, and you look at basically the hemodynamic and pulmonary vascular resistance. So here I have the chest x-ray on the left showing the pruning of the more distal pulmonary vessels. You can see. You can see also there is dilated pulmonary arteries where the arrows are on the top. You see the same thing on the right images, including this right ventricular enlargement on the lateral view. Sorry. Okay, so EKG is going to basically show here you have on lead 1, the red circle is basically indicating that there is right axis deviation. And then also RVH is represented with a very high, tall R wave in V1 and V2 as well. And then you see a little bit of right ventricular strain as well. So I'm not sure if you can see this very clearly, but this is basically a proposed diagram from the articles that I was reading regarding how to basically diagnose pulmonary hypertension. So first, you get a very good history. You're going to ask about the symptoms and the signs that the patient has, and if they are suggestive of pulmonary hypertension, you will do the chest x-ray, you will do ECG, and an echo as well. If the findings are compatible with pulmonary hypertension, you should consider the most common causes, like we said, congenital heart disease and chronic lung disease. And then you're going to review the history, look at the signs and risk factors. You will do pulmonary function testing, including the DLCO, which is basically the diffusion of carbon monoxide across the lung, and also consider chest CT. If they don't have ECG, chest x-ray, or echo findings compatible with pulmonary hypertension, then you must consider other symptoms or other causes of their presentation. So after you have done your testing on the left and you're diagnosing lung disease, you're going to basically see if there's any signs of severe pulmonary hypertension or right ventricular dysfunction. So if there are no signs of right ventricular dysfunction, you're going to treat the underlying disease. But if there are signs, then you're going to refer to a pediatric pulmonary hypertension expert. If you're also able to do a VQ scan, you can rule out the pulmonary, the embolisms. You're going to look for basically mismatched defects, and if there are, obviously you're going to treat, and if there are not, then you look on the lower right side. You can actually go to a pediatric pulmonary hypertension center with something called AVT testing, which I'm going to talk about, and they have other workup basically to rule out congenital heart disease. So the AVT testing is acute vasodilator testing, and this is basically to help determine if a patient who has idiopathic pulmonary artery hypertension can be treated with a calcium channel blocker. And it also can help to assess if patients may be operated on and assess long-term prognosis. There's no standard drug for testing, but usually they give inhaled nitric oxide 20 to 80 parts per million. And if there is a 20% decrease in the mean pulmonary artery pressure with a normal or sustained cardiac output and no change or decrease in the ratio of the PVR to SVR, then usually this patient will respond to a calcium channel blocker, and you could consider treating if they're like over the age of 1. The survival rate usually prior to the targeted PAH therapy with pulmonary vasodilators, the survival rate from the idiopathic pulmonary arterial hypertension was about 4.12 years. And right now, the survival rate is actually improving. There is like a registry called the US Reveal, which combines the adult and pediatric survival rates, and they found that at 1 year it's close to 96%, at 3 years 84%, and at 5 years 74%. In the UK, they actually did a study to show that the pediatric survival rates for idiopathic versus the congenital heart disease forms of pulmonary arterial hypertension, you can see at 1 year it was 92.3% for the ones who had the congenital heart disease, 85.6% for those who had idiopathic disease, and so on. So there's really no significant difference in the 5-year survival rate between idiopathic pulmonary arterial hypertension versus the pulmonary hypertension associated with like CHD. Patients with impaired congenital heart disease and PHVD do remain at increased risk for morbidity and mortality. The goal of treatment is usually to improve survival and the quality of life. There's also a lack of evidence, like we said, in the pediatric population for treatment guidelines. Children usually have like a different drug metabolism. They have difference in growth and development and the etiology of pulmonary hypertension compared to adults. So Uh, Generally, what we want to do is we want to treat the underlying disease. Remember that if you can find the underlying cause for pulmonary hypertension, it is better to treat that. So if they're hypoxemia, you're going to give oxygen. If they have OSA, you can do tonsillectomy. Also, we should try to early recognize and treat respiratory infections. And also, prevention is key for these patients. You want to make sure that they are properly immunized with the flu vaccine, the pneumococcal vaccines. And also, the most important, I guess, the most important thing is to remember is that these patients will always need a frequent follow-up evaluation with either cardiac cath or echo. And if you want to treat with medications, of course, the goal is to increase survival and also allow for normal activities of childhood while minimizing self-limitations. So some of the treatments I've just basically highlighted, the ones in red are the ones that you're going to need to know. But we generally can give oxygen to prevent vasoconstriction due to hypoxemia. We give diuretics like Lasix in order to decrease the ventricular filling pressure. However, remember that these patients should not be overly diuresed because the right ventricle usually is preload dependent. You can give digoxin to increase contractility to mediate the right heart failure, as well as anticoagulants like aspirin and warfarin if the cause is due to a thrombosis or thromboembolism. Calcium channel blockers help by promoting smooth muscle relaxation in the vascular smooth muscle. Um, and inhaled nitric oxide is going to be used in the acute setting only in like a hospital or ICU, and it helps to promote pulmonary vasodilation after cardiac surgery. The first line drugs that we usually get tested on are the phosphodiesterase inhibitors like sildenafil, which help to prolong vasodilation. Um, Endothelin receptor antagonists like bosentan, they help to prevent vasoconstriction. They're also noted to improve exercise capacity and improve long-term prognosis. And the prostacyclin analogs like treprostinil, epoprostenol, and iloprost, they promote vasodilation, antithrombosis, and antiproliferation of the pulmonary vasculature, and they help improve survival. So Denafil is actually improved in Europe in 2011. So for patients less than 20 kilos, they get 10 milligrams 3 times a day. More than 20 kilos, they will get 20 milligrams 3 times a day. There is an FDA warning on chronic use in pediatric patients age 1 to 17 years old. If there is any treatment failure, you can consider drug combination with inhaled prostacyclin for low-risk patients, and IV prostacyclin should also be added for high-risk patients. But remember that the most important thing, despite all these treatments, is that you want to have continuous repeat evaluation for the progression of the disease. Finally, we go to refractory pulmonary hypertension. This is when all of your medical combinations of drugs have failed. Usually what they do is atrial septostomy. It helps to unload the right heart and it improves cardiac output. This is usually considered in high-risk patients in the earlier stages of pulmonary arterial hypertension. So they have very low cardiac output. And you can also consider this prior to consideration of lung transplant. They have something also called a palliative POTS shunt, which is between the descending aorta to the left pulmonary artery. And then finally, the final treatment option is a lung transplantation. That's the last resort, basically. I have found also this. This is basically a summary of what we had just spoken about. This is an algorithm from the World Symposium on Pulmonary Hypertension from 2013. You see that you begin with the expert referral, right? You're going to consider your medications, and then you do AVT, or acute vasoreactivity testing. If it's positive and the child is greater than 1 year of age, you can give like an oral calcium channel blocker, and you continue it if it's noted to be helping the patient. But if it's not helping or the patient is negative and at lower risk, then you would start the endothelin receptor blockers or the phosphodiesterase that we were talking about. The patients should always be reassessed to see if they need like a combination of therapy, in which case you will consider adding the treprostinil. So the end all and be all is the lung transplant, and you always consider the atrial septicemia before that. The prognosis of the patients, there's no like really like standardized determination for which patients are going to do better than others. But what we have seen basically from adults is that we have that certain criteria can predict whether a patient will be at a higher or a lower risk of death. So some of the risk factors for death or a worse prognosis is if they have any signs of right ventricular failure. They have progressive symptoms despite treatment. They have syncope or failure to thrive, basically stunted growth. If they're in the functional class, WHO functional class 3 or 4, which we'll get to. If they have a significantly elevated BNP, natriuretic peptide, and if they have severe enlargement of the right ventricle or dysfunction of the right ventricle with pericardial effusion. Some of the hemodynamics, I think Dr. Kern would be better explaining these, but basically if you have the mean pulmonary artery pressure ratio over the mean systemic artery pressure greater than 0.75, if you have a right atrial pressure greater than 10 millimeters of mercury, and if you have a pulmonary vascular resistance index greater than 20 Wood units, these are all going to categorize you into the higher risk. So what was this? The 3 and 4 functional class basically means that a patient who is having either no symptoms at rest, but basically limitation of their functional activity when they're like around the house due to shortness of breath, or if they have symptoms at rest with severe symptoms, then they are considered to be basically at a worse prognosis. So that is all I have for today. I know it was like a very, very long lecture. I think any questions you can probably you can send to me on the group. I should be able to at least type them because I do have data on my phone. I just don't have it on my computer. Thank you so much.